Hey, friends and listeners of the Switch for Good podcast. Yep, that's you. I have some really exciting news. Dotsie and I have started a Switch for Good podcast Facebook group. We created it so we can build a community of fans that will help us improve the show and deliver on the topics that you want to learn more about. So we want to hear what your favorite content is, what you want more of, and what you want less of. And if you like the length of the show, Dotsie and I are always talking about the length of the show, right, Dotsie?
Yes.
We want to tailor our show around the needs and desires of our incredible listeners, almost 500,000 of you. And it's really simple to join. Just go to our Switch for Good Facebook page. That's Switch, the number 4, and then Good. And then click on groups. And there we are, the Switch for Good podcast chat. You can post directly in the group, share ideas, talk to other listeners, and connect with like-minded folks. So go, run, join our Facebook group and tell us what you want. Hello, everybody. Welcome to the Switch for Good podcast. I'm Alexandra, and I'm here with my co-host, Dotsie. Hi, Dotsie.
Hello.
You are going to be so happy with me today. I have a quiz for you.
Oh, Lord.
It's called the Miracle of Plants quiz. Are you ready?
Oh, okay. I don't even know what that could be, but yes, I think I'm ready.
Okay, so these are 4 questions. Three of them are multiple choice. So we all love multiple
Thank God.
choice.
Okay.
All right. Okay, so what should not be regularly consumed by pregnant women because of its anti-inflammatory powers? It has so much anti-inflammatory powers that it's recommended that pregnant women not take it. Chamomile tea, carrots, broccoli, or lemon juice?
Wow. I'm going to say it's either chamomile tea or lemon juice. Is it something else? I've never heard that they can't have broccoli. That would be terrible. I know a pregnant woman eating a ton of broccoli right now. So if it's that, I got to call her. We got to get off the podcast and call her. Yeah, I don't know.
Pick one.
Okay, chamomile tea.
Yay! Ding, ding, ding!
Yay! Really?
Yes.
No.
So just like women are recommended not to have aspirin, chamomile tea causes premature constriction of the fetal ductus arteriosus. So regular consumption is not recommended. There you go.
Wow.
Isn't that interesting? Yeah.
Yeah. Well, I'm also going to carry that information to her. It's just to make sure she's not having lots of chamomile tea every night. Goodness gracious. Yeah. Because I know usually with pregnant women, I mean, everything they tell them that they can't eat it's all animal foods. I mean, her whole list that her doctor gave her is all animal foods. You know, it's like it's shellfish and all sorts of stuff, but it's all animal foods because the bacteria.
But remember too that, you know, most of our medicines are made from plants is my understanding. And so plants can have really medicinal effects in one situation, but if you're pregnant, not so good.
Right.
That's how powerful they are. So,
Gosh.
Okay. What plant can help lower your cholesterol and help with your diabetes too? Okay, so I've got 4 for you. Either amla, Indian gooseberry, acai, or pomegranate juice. What can
amla powder? Amla.
Yay!
I knew that one.
So good. And actually, it was I kind of had a little trick in there because Indian gooseberry, which was the second choice, is also called amla. So if you see,
I didn't even know there was a trick. You a little sneaky.
I've been taking I ordered amla powder just because it seems so healthy.
Yeah,
super bitter, but you only need to take like a teaspoon. You can put it in a shake, and you can't taste it. So
yes, I did order it for Kirk because, as I've talked about many times on the show, he has hypercholesterolemia, and so Cyrus Kambata helped me, as that's where I first learned about amla and ordered it from him. And Kirk is supposed to be putting it in all of his shakes, although it doesn't seem to be, the package does not seem to be decreasing in size. So I don't know that it's actually happening. So maybe I should start taking it.
Check.
Because it's so
It's
good.
only a teaspoon though. So yeah. And Dr. Cyrus Kambata from Mastering Diabetes.
Yeah.
He's a font of information. Cool. All right. Okay, what fruit enabled the mass production of penicillin in the United States during World War II? the strawberry, the melon, tomato, or cucumber?
I'm going to say tomato.
It's actually the melon. And let me tell you a story about it, because there's no real logic behind this, but in 1943, this lab assistant working in Peoria, Illinois, her name was Mary Hunt, she found this cantaloupe at this local market, and it was covered with mold, because remember, penicillin is developed from mold. So this mold turned out to be a really productive strain of penicillin. And so then the United States was able to mass market it, mass produce it, because in the beginning of that year, they were only able to make enough penicillin for 180 severe cases. And by the end of the war, they'd increased their production to 100 billion units per month, which from 400 million units a year. So, wow, right?
Total wow. Oh my gosh.
So it was this highly productive penicillin mold on melon. Aha.
Wow, okay. So that is good. That's so okay. I'm 2 for 3. Okay.
Yeah, you're still winning.
Oh, good. Okay.
All right. This one is not
multiple choice.
Thank you.
This I was afraid you were going to say that, so that's why I knew to say.
But very important. What vegetable is thought to keep vampires away?
Oh, this is like super easy, isn't it?
Well, it's not. I don't know if I would have got it, because I don't watch horror movies, so I wouldn't know.
What? You're like in them all the time.
I know, but I don't like watching them, really.
This is,
okay, let me
our whole audience knows this, and they're like, send it to my brain, people, send it to my brain.
Yeah, it's a vegetable.
Is it something acidic?
No, it's something grows under the ground. It's also
onions.
No. Maybe onions, but what's the other one?
Garlic.
Yes! Woo!
So
just in case there are any vampires, folks, you got to bring your garlic with you.
Okay. Good to know for the next time I run into a vampire. Okay. All right.
Good job.
I got a little help with that one, but anyway.
That just shows you all the power of plants. And now let's go on to our guest, who's going to also talk about the power of plants.
Yes, we are so lucky. It's a lifestyle medicine doctor and an endocrinologist, and we're going to talk about diabetes, just like we have with Cyrus Kambata and Robbie Barbera from Mastering Diabetes. So we're going to go in deep, and it's going to be awesome. Thanks for the quiz.
Good job.
Thank you.
Arti Thangudu is a triple board certified MD specializing in endocrinology, thyroid, and diabetes. She's also a mom to 2 adorable kids and runs her own private practice in San Antonio, Texas. It's called Complete Medicine. But she didn't stop there. Arti is determined to prevail over the diabetes epidemic in her city. With a diabetes rate 6% higher than the national average, Dr. Thangudu's integrative practice is helping patients battle the disease and preventing new patients from developing it. She's also constantly learning. Dr. Thangudu is a certified in plant-based nutrition from Cornell University and underwent a 200-hour yoga teacher training, all to help her patients thrive. So tell us, Dr. Thangudu, what don't you do? And welcome to the show.
Thanks so much for having me. I'm excited to be here.
I wanted to start off first just clarifying what you do. You're a lifestyle medicine doctor and an endocrinologist. Can you explain what both those terms mean?
Yeah, absolutely. So my second, I guess, board certification, but my main board certification is in endocrinology, diabetes, and metabolism. And so as an endocrinologist, I'm basically a physician for patients with hormonal problems. The most common issue that I deal with is diabetes and metabolic disease. So metabolic disease means things like hypertension, hyperlipidemia, cardiovascular disease that all sort of come together as metabolic disease. And then we also deal a lot with thyroid disease, hypothyroidism, hyperthyroidism, thyroid nodules, thyroid cancer, and other hormonal diseases like pituitary hormones, female hormones, adrenal hormones. So that's what endocrinology is. And then later, I became board certified in lifestyle medicine because I recognized that people, especially my patients with diabetes, but patients also who struggle with overweight, obesity, they just weren't getting better, right? We were throwing medications at them, but generally from a population standpoint, they weren't getting better. And even generally from just individual patient interactions, people just seemed to be stagnating. And so I thought, gosh, there's got to be a better way. And as I was sort of figuring out what I wanted to do when I grew up after I'd finished my endocrinology fellowship, I stumbled upon lifestyle medicine. And I really think the two jive very well together. And since then, I started my own practice to take a lifestyle focused approach to metabolic disease. So of course, I still use medications. I'm still a prescriber, but not just a prescriber of medications that you get at a pharmacy, right? Lifestyle, diet, exercise, sleep, stress, these are all very, very important things that can improve or worsen chronic metabolic disease, are probably the most important things that we can do to affect metabolic disease. And so my practice now takes a lifestyle focused approach to metabolic diseases.
Okay. So you mentioned some of the diseases like that you treat, like diabetes, and some of the issues of the hormonal system. But if we could peel the layers back even more to start this off right, so we just have a complete 360 understanding. What exactly does the endocrine system do in our bodies, and how does it malfunction?
So the endocrine system so when we think of medicine, sometimes we think of things like compartmentalized, like your GI doctor, like your cardiologist, your lung doctor, but the endocrine system does not have a specific location. It affects the entire body. And it does that through hormones. Every single organ in your body is affected by your hormones. So when we say, well, where can it go wrong? There's such a complicated question. There are so many endocrinologic diseases. Diabetes being the most common, it can be a problem with insulin. Now, that can be insulin production or insulin use in the body. Both of those things kind of factor in. And insulin is produced by the pancreas, but used by all of your organs, most specifically the muscle cells, but we need insulin everywhere. Other hormones that can misfunction are thyroid hormones. That's probably the next most common. You can have underactive thyroid hormone, overactive thyroid hormone, and those have various treatment modalities. We have cortisol or adrenal hormones. The adrenal glands are these fatty little glands that sit above your kidneys that are involved in lots and lots of different processes in the body, but are definitely essential for life. So we deal with those. Male and female reproductive hormones, they can affect fertility, as well as many other functions of the gonads or the reproductive organs. So loaded question, lots of answers, but no specific direct answer for you.
Okay. Well, let's talk about some of the endocrinology problems that your patients come with, and let's start with diabetes, because, as I mentioned in the intro, this is a big issue not only in Texas but actually in the United States. And we've had Dr. Cyrus Kambata and Robbie Barbaro on the show from Mastering Diabetes podcast. I think you know them, and you have a lot of the same philosophy as they do. Most doctors seem to immediately put patients on metformin or some kind of medication, even when they have a pre-diabetic, when their A1C is just under diabetic. You claim that your clinic is the only diabetes reversal clinic in Texas amidst this diabetes crisis in the state. Tell us what you're doing differently. If I would to come in with an A1C that was high, maybe on the borderline of pre-diabetic and diabetic, what would you tell me to do that's different from the other doctors in your state?
Yeah, so I actually prefer to use the word remission over diabetes reversal, just because it's such a complicated amalgam of hormonal abnormalities that actually gets a patient to a state of diabetes. But basically, what we mean with diabetes remission is when a patient has a normalized A1C and they're off of all of their medications. Now, I have patients who have done that. I also have most of my patients are at least with a better A1C on less medication than they started with. And so I go through a process of deprescription, which is removing medications when we can. And so there are two ways that I try to attack this problem. One is teaching patients evidence-based lifestyle techniques. So there's so much information about nutrition and diabetes. Like if you Google that, you would probably get like 1,000 hits, right? Just so many people spewing different approaches to nutrition with diabetes, some very dogmatic approaches, like this is the right way and the only way. I try to take a much more patient-centered approach because everybody's an individual. Like you cannot expect every person with diabetes to follow a specific protocol. Like everybody's different. Everybody has different likes, different dislikes, different preferences, different lifestyles, different access to different things, different cultures. And so my first step is I take a lot of time to get to know my patients. Like their diabetes history, yes, but who are they and what does their day-to-day life look like? I do something called the day in the life. Ask the patients to tell me like, when do you wake up? When do you sleep? What do you do during the day? You know, what does your day look like? And what are reasonable changes or tweaks that we can make to your day-to-day to facilitate you to get to your next step? And your next step doesn't have to look like somebody else's next step. I do recommend a plant-forward diet, a plant-centric diet. For some people, that's being completely whole food plant-based with no animal products. And for some people, that's eating less McDonald's, you know, that's eating one plant-based meal a week. So really try to focus on the person in front of me, not just some sort of dogmatic approach that is blanket for everybody, because I don't think that will work as effectively.
But what works in terms of diet ideally? Because I know that we've talked with some doctors who acknowledge that sometimes doctors don't ask their patients to rise as high as they could rise, or at least to even recognize that they don't have to go there if they don't want to, but this is ideal. What would be for our listeners the ideal diet? Is it just plant forward, or is it completely take out the animal products or the fat or something?
A diet that is ideal for a patient is a diet that they can sustain. I recommend a plant-based diet, a diet that's rich in whole grains, legumes, fruits, veggies, mostly non-starchy veggies, and try to get patients as adherent to that as possible.
Why don't we talk about back up a bit and talk about how different food, animals food, plant-based food, they say, food is medicine. And we know that is specific to plant-based food for sure. If that's something that, obviously you're suggesting, then you believe that too. So how do animal foods affect our hormones? And then how do the plant foods affect our hormones?
Yeah. So one thing that we talk about a lot, and I talk a lot about with my patients, is how fat can affect insulin resistance. So with patients with diabetes, type 2 diabetes especially, but now we even have type 1s who with insulin resistance, saturated fat can initiate insulin resistance and worsen insulin resistance. So when we start to eliminate that from a patient's diet, we see quite remarkable changes in insulin resistance in our type 1s. So I've seen before my eyes, like patients with type 1, we are very on top of like exactly how many units of insulin they need for X number of carbs, and how much 1 unit of insulin will drop their blood sugar. We're very mathematical and specific about that with our type 1s. And there's something that we use called an insulin to carb ratio. So that means how many units you need for every carbohydrate. And I've seen people switch from like a ketogenic diet, which is attempted a lot by our patients with diabetes. I've seen patients drop from an insulin to carb ratio of 1 unit for every 6 grams of carbs to tripling their insulin sensitivity in a matter of days to like 1 to 16, 1 to 18, 1 unit for every 16 to 18 carbs. So, and that's not with weight loss, right? There's this, people think that you need to have a huge amount of weight loss or significant weight loss to improve your insulin sensitivity, when really that's not necessarily true. And it's kind of interesting because as an endocrinology fellow, we didn't really learn any of this, but there's studies dating to like the 1930s demonstrating that fat can acutely impair insulin sensitivity. So it's not surprising based on this data that we've had for a long time. It's just for some reason not in the traditional model of medical education.
So does the fat in animal products, is it worse than the fat in a plant product, or is all fat equal when it comes to hormones and diabetes?
Especially saturated, right?
Yeah, so saturated fat is really only found in animal products. The only plant-based product that you really see it in is coconut, and that's thought to be the biggest culprit. The interesting thing that definitely deserves more research by people probably smarter than me is how poly and monounsaturated fats affect insulin resistance, because there are some scientists who say they don't, but then you'll have patients with type 1 diabetes who many of them say, like, if they eat a very strict plant-based diet, but then that's low fat, and then they eat an avocado, they notice changes in their insulin resistance. So that's kind of to be determined. But I think most of us who read cardiovascular data and diabetes data are more in favor of replacing saturated fats with mono and poly unsaturated fats.
Okay. When do you think the traditional medical field will get up to speed with what you've just been talking about in terms of saturated fat, and that being causal and problematic, and not just solving the symptoms by eating less processed sugar or less sugar? Because I mean, I don't think I've ever met a diabetic who is not entirely and totally focused on sugars, and that's it, as far as their diet goes.
And the younger generation of doctors they seem really interested in learning about nutritional science and how they can help their patients with lifestyle. Maybe they're just more green and not in the system, but I think, I'm like the never-ending optimist, but I think that people are waking up to this. And I don't know if I would have exactly said those same words 3 years ago or 2 years ago. I mean, 4 years ago, I was completely in the dark about this myself. So I think we just got to keep talking about it, keep spreading the word, keep looking at the science, and people will come around, some people much more quickly than others.
I have a good friend that's a scientist that said something that I thought was fantastic. He said, people think if they need to lower sugar, then they need to eat less sugar. But that's like saying, if I wanted to get smarter, I should be eating more brains. So if we say the problem is fats, oils, saturated fats, animal fats, fats make it hard because it stops basically like the muscle sponge from pulling sugar out of our body. So would you explain that mechanism? Because I still to this day have been explained it 3 or 4 times, and I still have a difficult time explaining the root of the problem, right? Because we're talking about the actual root of the problem versus just kind of fixing the symptoms, which is what diabetics are doing that are only focused on the sugar, the way that I understand it.
Yeah. And a shameless plug, I actually have a YouTube video that explains this. So if you want to watch it 100 times because you need an explanation, it's free for all on YouTube. But basically, insulin resistance occurs because, so normally the pancreas secretes insulin in two ways: basal and bolus insulin. So basal insulin is the pancreas sputtering along all day long, countering the sugar that is continuously produced by the liver because the body uses sugar as energy. So, for instance, when you're sleeping and not eating, the liver is producing energy for your heart to function, your brain to function, your lungs to function, all of those things. So the pancreas constantly produces insulin at a basal level. Now, at meal times, when, for example, we eat a cupcake, our pancreas secretes a little burst of insulin, or bolus insulin, to counter the sugar that's come from the exogenous source, the meal. Now, insulin is countering that sugar to prevent it from getting too high. Now, how this works is, for example, when the sugar is high in the bloodstream, normally insulin opens up a little gate between the bloodstream and the muscle or the cells and says, hey, sugar, go into the muscle, and the muscle uses it for energy, and all is well in the world. The sugar gets lower, it gets taken up by the muscles, all is well. Now, when we have excessive fat, dietary fat, body fat, that fat impairs that signaling. So now, when the sugar is high in the bloodstream, insulin's trying to open the gate to let the sugar into the muscles, but the gate is stuck. So insulin starts getting higher and higher and higher because it's trying to scream at this lock to open, but the lock is stuck. And so insulin levels go high. And while insulin is all well and good in normal levels, when insulin levels get high, it makes you gain more weight, which worsens insulin resistance. So we get into this vicious cycle of high sugar, high insulin, weight gain, worsened insulin resistance. So that's one way that it works. Now, the liver, remember, that was making sugar all day long, normally when the blood sugar gets high, like you ate that cupcake, insulin says, hey, liver, slow down. We got sugar from somewhere else. You can take a break now. But when we have excessive fat, the liver gets all filled with fat as well, and that signaling gets disrupted again. So when you eat that cupcake, the insulin tries to tell the liver, hey, stop making so much sugar, we've got enough, but the liver isn't listening. So the liver keeps making sugar willy-nilly while the sugar's already high in the bloodstream. And so insulin's getting higher, trying to scream at the liver to stop making sugar. Liver's not listening. And so we have high insulin, which leads to weight gain, worsened insulin resistance, and the cycle, it's like a vicious cycle again.
Is a really severe diabetes. The problem is it is not being pulled out of our blood to be utilized. And if the blood sugar hangs out at high levels for way too long, it binds to things that it shouldn't, like blood vessels in the eyes. And that's when people go blind, or in people's feet or toes, and they have to be amputated. So the extreme version of it, is that a correct explanation of why that ends up happening?
So it's more of an osmotic process, but basically, yes. And there's vascular impairment, like vascular walls get stiffened, thickened. It's not just that the sugar is attaching to it, but like there's a physiologic cellular process happening there due to the high sugar that affects basically all the vessels in your body. So kidneys, big vessels like in your heart, strokes, your eyes. Hopefully not that many people are going blind from diabetes because we have very good treatments for it, but that's why we do screen for diabetic retinopathy every year, and we try to get our patients in diabetic neuropathy as well. So yeah, there's an osmotic process, and there's also a vascular endothelial damage that occurs due to high blood sugars that cause these big problems.
Thank you.
I think the reason that people get confused, because I even mentioned diabetes this morning to my husband when I was telling him that we were interviewing you, Dr. Thangudu. And I immediately thought sugar in my head. And I thought, no, Alexandra, it's the fat. But the reason we think of sugar so much is because we test for sugar, and it's the symptom that comes after we've had excessive fat in our muscles or in our organs. Is that correct?
Yeah, and so that's the whole thing about nutritional education on diabetes, because you're right, we're so focused on the sugar, and I don't recommend that people have a bunch of processed sugar, high fructose corn syrup, and definitely like those are not good for diabetes or good for anything. But when we fixate on the symptom over the root cause, we can get ourselves into trouble. So most patients with diabetes think that they can't eat a banana because it's going to skyrocket their blood sugar. But was it the banana's fault, or was it the cheeseburger that you ate before you had the banana? Well, the cheeseburger that was high in fat is what made you insulin resistant, and therefore glucose intolerant. So now your blood sugar rose because you had the banana. But I personally have worn a CGM, a continuous glucose monitor, and my blood sugar does not spike with the banana. And so that's because my body can tolerate glucose because I'm not as insulin resistant. But if I was eating a cheeseburger before it, maybe my blood sugar would rise more. And if people with diabetes who have even more impairment in their glucose tolerance are eating that way, and then they're trying to eat fruit, then yeah, their blood sugar is going to spike. But telling them not to eat the banana is more trying to tell them to treat a symptom versus, okay, we need to cut out the cheeseburgers or limit the saturated fat, or talk about weight loss or things like that are actually going to fix the cause of the problem. So then they can enjoy healthy foods like bananas and apples and other nutrient rich foods.
And do you, when somebody comes into you and they haven't yet started, they're going to be on the process of changing, do you recommend that they don't eat a lot of sugars, just because, as Dotsie mentioned, sugar in your bloodstream isn't healthy, causes, and you mentioned, hardening of the arteries and problems?
Yeah, so it depends. So I don't recommend that my patients don't eat fruit, and that certainly has sugar in it. But in terms of refined and processed sugars, yes, I think minimizing that is an important piece of a healthful diet. So cutting out the sodas, the juices, sugary sweetened beverages, high fructose corn syrup, those really highly processed and refined sugars are not the most healthy, but certainly fruits are totally on the table in my book.
You've had some some great success stories with diabetes. Can you share with us one or two?
Yeah, gosh, where do I start? So I think the most exciting thing for me to do is, or one of the most exciting things for me to do, is getting patients off insulin. And because insulin, it's literally a pain to take, but it's also just, it's annoying to have to deal with this medication that can drop your blood sugar. People have to eat to keep up with their insulin.
Yeah.
Insulin makes you gain weight. So while it's great at lowering blood sugar, from a metabolic disease standpoint, it's not a very clean medication. It doesn't reduce, worsens insulin resistance almost. So, by making you gain weight and increasing your appetite. So I love getting patients off insulin. That's always my goal when I have patients who come in on insulin. And so I've had several patients that we've been able to discontinue insulin on, and massive. So I had one patient who came in with an A1C of 9.4, and she was on about 100 units of insulin a day. And she's just an awesome patient, but she had sort of failed primary care, right? She had been seen by her doctor for a while and wasn't making any progress. So we did the whole spiel. I counseled her on plant-based diet. We changed up her medications and put her on a continuous glucose monitor, which I love using because it gives patients that instant feedback on how their lifestyle is is affecting them in real time. And within 2 weeks, she was off all of her insulin. Like
Wow.
it does not take that long. And her A1C has been 5.7 for the past, I think, at least 6 months. So she was able to get off the insulin and, more importantly, maintain being off of the insulin. And that's from 100 units. So that's pretty exciting. And I have a few other stories that are similar to that, patients who came off insulin. And the thing with insulin is it's hard to take because it's injectable, but it also causes hypoglycemia, which patients are terrified of having. So if their blood sugar is like in a normal range, like 80, 90, they might eat to try to keep up to ensure that they don't have a hypo event. And then that makes them gain more weight. And it's just this vicious cycle that I love getting patients out of. And all of a sudden, when patients are off of insulin, they're able to lose weight and they're able to eat more healthy because they don't have this, they aren't like shot in the foot by their medication regimen.
Mm-hmm. So what did she do? Did she just make this meteoric change to everything that was on her plate from when she walked out of your office until the 2 weeks later?
Her insulin wasn't dosed properly. I see this in probably 97% of patients who are referred to me on insulin, maybe 100%. Most patients aren't on good doses of insulin. So
too much or too little, do you see?
Incorrect dosing. So most patients are over basalized. So that means that they are on high doses of long-acting insulin without adequate or any mealtime coverage. So, and that's not physiologic and it doesn't work. And so people's A1Cs are poorly controlled because they're having highs and lows and kind of yo-yoing. But I would say, I don't think I've ever had a patient referred to me on an appropriate dose of insulin.
Why? Why are they being misdosed?
85% of patients with diabetes are managed by a primary care physician, and they just don't have the expertise for the most part, to manage insulin. And it's not anybody's fault, right? It's training and physician endocrinologist shortage. It's very hard to get in with an endocrinologist. Some insurance plans don't cover specialist visits. There's so many barriers to seeing an endocrinologist. Like most endos have a 3 to 6 month wait list. And most people don't know that they're supposed to see an endocrinologist if they have diabetes. So what ends up happening is they end up seeing an endo when they are poorly controlled for a long time and they're starting to have complications. And then the primary doctor's like, okay, you really need to see endo now. And, I wish it was different where every diabetic had access to expert level care. And then once we get them, straightened up, then we can send them back to the PCP, but that's just not what the system is creating at this point, which is why I'm on social media, because I want people to have access to our specialty without, having to jump through the hoops of having it. And it all comes down to, the barriers of what limits everything. And endocrinologists are going to just continue to decrease in number because of the reimbursements. You do extra training and you don't get paid as much as you would if you didn't do that training. And so it's kind of like demotivation from doing the extra training. I've kind of created this different niche to make it work and hopefully to support the field, but it's really sad because we're so needed and we can really transform patients' lives, and it's just not valued by the current healthcare system.
You do telemedicine too. So
I forgot to tell you guys that, but I moved to Houston for my family's in Houston, but I retained most of my patients from San Antonio. So I do pretty much all virtual now. And I can see patients anywhere in Texas.
Oh, and can you do telemedicine for folks outside your state?
No, due to license, because you have to be licensed in the state that you do telemedicine, and licensing is not for the faint of heart.
Frustrating.
It's a really challenging and costly thing. And my practice is pretty full here in Texas, so it just doesn't really make sense for me to put myself through that at this point. But I do offer like some remote second opinions and stuff. So if someone really is interested in getting an opinion from me, they can absolutely reach out, and I'll do my best to help them.
Okay, great.
Let's talk about the adrenals. I had to greatly supplement with adrenal supplements 25 years ago, coming out of anorexia, because they were so taxed. And, that was just obviously physical stress, but there's so many different types of stress, especially today. So people that are dealing with adrenal fatigue, due to all the myriad types of stress that they're under, what are the symptoms, first of all, that they may notice that may alert them that it could be their adrenals? And then how do you help people through that?
So adrenal fatigue is actually not a true evidence-based medical diagnosis. It was actually created in the 90s by, I think it was a PharmD who basically created this diagnosis to sell supplements. So it
sounds like I bought in.
Well, you look great, and so hopefully, and you're talking with us. So hopefully things were good. And anorexia is so complicated that I don't want to like point a finger at anybody who is treating you. They may not have made any mistakes. So yeah. But basically, adrenal fatigue is not accepted by any reputable endocrine society in the world. So, but the adrenals are responsible for secretion of multiple hormones, cortisol being the main one that most people are concerned about. There is something called adrenal insufficiency, which is a evidence-based accepted medical diagnosis that that presents with things like abdominal cramping, nausea, weight loss, hyperpigmentation of the palms sometimes. Usually it's an autoimmune disease and it is life-threatening. And so people can present with like orthostatic hypotension, dizziness on standing, things like that. And it is something that needs to be treated, and people often land in the hospital because of it. So that is probably the most common adrenal issue that we deal with, but it's still not super common. And it's basically the adrenals aren't producing sufficient cortisol because they're not getting sufficient cortisol impulses or stimulation from the brain, or there's a problem with the actual adrenal glands where they're not producing sufficient cortisol.
So I was under the same assumption as Dotsie. I knew an athlete, professional triathlete, who had adrenal fatigue, and my understanding was that his cortisol had been kept going and being used up. Essentially, he'd stressed it, and so I was under the impression that also when people are in not physical stress but emotional stress, their cortisol goes off unnecessarily because we're not being hunted down by lions anymore, but we are experiencing the same kind of stress that makes us feel like we are. Is that totally off base? So the adrenals don't get tired from releasing cortisol from stress, either physical or emotional?
No, they don't get tired. And in fact, that is their role. That's what they do. So when you're in physiologic stress, your adrenals should be producing more cortisol. That's exactly what should be happening in the body. And emotional stress doesn't affect them so much, but it may increase your cortisol, but it's not going to be pathologic where we have evidence that it's going to demonstrate that it's elevated on our evidence-based ways of testing for cortisol. There are a lot of tests out there, like the Dutch test, salivary test, urinary test for cortisol, that are non-evidence-based, that people are selling, like functional medicine providers and stuff like that, but they're not evidence-based. And when we actually compare them or read the data to support that they say supports those tests, it's like terrible. It's like on really small patient samples. When you actually read the data, they're just worthless, basically. And so there's a lot. You guys are not alone. Like, there's so much misinformation in this world, and especially in the space of adrenals. The scary part, though, is adrenal supplements most often contain two things. that are dangerous. One is bovine adrenal gland. So basically they dry and pulverize a cow adrenal and put it into a pill. And when people ingest those, they can have adrenal hormones from the cow, right? So when you get cow cortisol, of course you're going to feel better, because everybody feels better when they take a steroid in the short term. I took steroids for an ear infection years ago, and I ran at like 10 miles per hour on the treadmill, no joke, because like it's a steroid, right? Like it makes you euphoric and gives you that boost, takes away all your pain. But over time, when we get steroid from an exogenous source, our brain says, hey, I don't need to make it anymore, so I'm not going to. And so the brain stops telling the adrenal glands to make the adrenal hormone. The adrenals, your natural adrenals, stop making adrenal hormone. And the second that you stop that pill from the cow, then now you don't have any. And so now you have what we call iatrogenic adrenal insufficiency. So now you have that life-threatening condition that I was talking about because of the pill that you were taking. So that can be really dangerous. And then Mayo Clinic did a study of adrenal supplements where they actually looked at them under mass spec. Because supplements, they don't have to contain what they say on the label. They can contain whatever the heck they want because they're not FDA regulated. And so most of them contain T3, so thyroid hormone, active thyroid hormone, which can, if you don't have thyroid disease, can cause palpitations, cardiac arrhythmias, osteoporosis, all kinds of things that we don't want to give our patients.
May I ask you a question about depression? Because I hear that people say it's chemical, and I wondered, is it within your scope? Is it hormones that cause people to be depressed if they're chemically depressed?
So, so depression, sometimes it is affected by hormones. And sometimes when we talk about chemicals, they're talking about neurotransmitters like epinephrine, dopamine, those kinds of things that aren't hormones, but they're neurotransmitter chemicals. But hypothyroidism can certainly cause depression. It's one of the common symptoms of hypothyroidism. And so if a patient has depression, we always recommend screening for hypothyroidism and treating it, because people can really have improvement in their depression with thyroid hormone if they need it.
I was curious about hyper and hypothyroidism and as being endocrine issues. Do we bring those on ourselves through the unhealthy ways that we eat or live, or stress or depression or anxiety, or can it also be just a part of the body that goes whacked out that we don't have any control over or some control over?
So the most common causes of hyper and hypothyroidism are autoimmune diseases. For hypo, it is Hashimoto's thyroiditis. And for hyper, it's Graves' disease. And usually these are genetic. And now some people have the antibodies, but never actually develop the thyroid disease. Whereas some people do like really early, like congenitally. So it's a little bit unpredictable. And the level of antibody doesn't correlate with the progression of disease either. Like, for example, I've had patients who have Hashimoto's antibodies elevated to like 30,000, but their thyroid function tests are totally normal. They don't need supplement. And then I've had people whose antibodies are elevated to like 9 and they do need hormone. And I've had patients who are like, have had hypothyroidism since they were babies. And some people develop it when they're like in their 90s, and so it's kind of all over the spectrum. But the important thing to know is we don't have to target the antibodies, because there's no evidence to support that decreasing the antibodies actually slows progression of the disease. Now, do we know of like very specific lifestyle factors that affect progression of the disease? well, no, unfortunately, we don't have great science to say, hey, if I do X in my lifestyle, then my risk of hypothyroidism is going to be less. But hypothyroid has very, very non-specific symptoms associated with it that sometimes don't improve with medication, like fatigue, mood issues, constipation, and for those symptoms, lifestyle is hugely, hugely important. So if you have hypothyroidism, and this is kind of a silly thing, but if you have hypothyroidism and you're fatigued and you're sleeping 4 hours a night and your thyroid is normal, well, we got to change the lifestyle too before we blame the thyroid, right? And so I think lifestyle goes really hand in hand with thyroid treatment.
When you say lifestyle, of course, you mentioned diet. What other factors are included there?
So diet is of course huge. Exercise also improves insulin resistance, which we all want to do. Sleep and stress, like getting adequate sleep. You wouldn't believe how many patients I see when I do my little day in the life. They're getting 4 hours of sleep a night, 6 hours of sleep, or they're waking up every 2 hours, or they're sleeping not restfully because they have sleep apnea, or they have a child in their bed or something like that. And people kind of forget how important sleep is. And when we fix that, well, all of a sudden they start losing weight, or they feel less depressed, or they feel less fatigued. And it's such a basic thing that sometimes we take for granted. But that is one thing that I try to fix in pretty much all of my patients, because I know how I feel when I don't sleep at night. I know how my kids act when they don't sleep well. And so I think we all kind of respond to lack of sleep, even if we don't necessarily give sleep the credit it deserves. So sleep and stress, management of stress, resiliency. If we're not sleeping, it's hard to manage stress. It's hard to have that resilience. But also, even if you're getting adequate sleep, developing the tools to really cope with what's thrown at you. Because as we all know, our response is more important than the stressor usually, right? Like if I get in, God forbid, if I get in a car accident today and I'm healthy, fine, I could let it ruin my day, or I could say, hey, I'm grateful that I'm alive, right?
Mm-hmm.
And that can really just affect your entire outlook. And everything, the body's a system. So our outlook affects our physical and emotional health.
Yeah. I always said if I was a prisoner of war, like all you have to do is do sleep deprivation, and I will tell you anything you want to know in like 24 hours. Like I am so it affects me just so much. I'm like a 9 hour a night person, and I'd really like to be a 6.5 or 7 because it's a little more productive. But I did race across the West with a group of ladies that were trying to break the record, and I don't know, whatever, but 2 months before they asked me to do it, because they're like, oh, we'll get this, whatever champion cyclist to do it with us and we could break the record. Well, everything was fine the first 10 hours. And then we hit night and you don't sleep at all. And my whole body shut down. Like my whole body, like everything, my whole digestive system shut down. I think my endocrine system completely shut down. My brain shut. I was just not even functioning. It was crazy. And they were okay. I mean, they weren't, deal with it great, but people are different, right? To my point, right? Like and I think that we think that if we, get less sleep and can be more productive during the day, then that'll be less stressful because we'll get more done, and it's stressful to not get things done. But I don't know. I've learned the hard way that that's just not the case.
I was actually reading some book, and they cited some study. I didn't read the study, so I don't know how good the evidence was, but they said the finding was that, most of us think, I'll sleep when I die, right? But productivity is not inversely related to sleep. So what that means is, like, if you sleep less, you are not going to be productive to make up for that sleep deficit. So a task that takes you 2 hours when you sleep 6 hours a night may take you 10 minutes. If you sleep your 9 hours of sleep. And so I'm actually an 8 to 9 hour person too. So I completely feel you.
I'm so happy to know this information too.
Yeah. It actually is not, while it would make sense to think that it affects our productivity if we're sleeping a lot, it actually improves our productivity. So we're more efficient at our tasks the next day.
It's not just an amount of hours. It's how you use them.
Exactly.
Wow. Awesome. All right. I'm going to keep sleeping.
Yes. Keep sleeping. Just don't get that out of your lifestyle, because that's definitely gonna, lack of sleep increases your risk of diabetes, hypertension, heart disease. Sleep apnea is a major risk factor for all of these things. So it is highly, highly underrated and very, very important.
Yeah. Thank you for that.
Tell us, I know you also, you have a lot of information on your website on low testosterone and some YouTube videos also. Can you talk about what are the symptoms of low testosterone in men? Mm-hmm. What causes it, and how can we get it back to healthy levels for them?
Yeah, so the most specific symptoms of low testosterone in men are erectile dysfunction, inability to have erections, loss of morning AM tumescence or morning erections, and loss of libido is something that people commonly report with low testosterone, but also can be very multifactorial. Less specific symptoms of low testosterone are muscle loss, kind of weakening of the muscles, fatigue, but these can be related to all sorts of other lifestyle related things like lack of exercise, lack of sleep, impaired sleep, poor diet, so the thing that is most specific are those erectile issues. Now, I would say, kind of like my insulin issue with referrals, most people on testosterone therapy have not had an appropriate diagnosis of hypogonadism. Mm-hmm. So testosterone, kind of like cortisol, peaks in the morning and then falls in the rest of the day. So the labs that we have, the assays that we use to measure testosterone, the reference ranges are made for the morning. So I see patients come in all the time. They have some random testosterone drawn at some random hour of the day, and like a radio immunoassay, not the most accurate assay, and they get put on testosterone. And I'm like, where's the diagnosis? There's no diagnosis here. This is a incorrect lab drawn at the incorrect time. And now you're on this medication that increases your risk for cardiovascular disease, clotting, pulmonary embolism, all these things. And so it's very, very important that people get appropriate diagnosis and appropriate counseling on risk-benefit ratio of testosterone before they get put on it. There are tons of testosterone clinics out there, tons, far more than your evidence-based board certified endocrinologist, right? So, and they're just churning people through their clinics and making money off of them without adequate and appropriate diagnosis. And it's very, very scary. I mean, my husband's an ICU doc, and he sees people come in with pulmonary embolisms, heart attacks, really, really things that we don't want to be giving our patients because of inappropriate hormonal therapy, specifically testosterone. So I'm glad that you guys brought this up, because clearly I'm very passionate about it, but it's also just so important for our public to be aware so they can advocate for themselves. So appropriate diagnosis of testosterone or hypogonadism, low testosterone, can be achieved with a morning testosterone by a specific lab called LC-MS, liquid chromatography and mass spectrometry. And we calculate a bioavailable testosterone using that number plus a sex hormone binding globulin and albumin drawn at the same time. There's a calculator online, because I'm not the best at math, that basically tells us if the testosterone is low and incorporates the binding proteins in our body that affect how much free testosterone is available for the body to use. If it's over 100, we're in the clear, not dealing with low testosterone. If we're under 100, then we need to be talking about therapy. And typically, we calculate that twice. We do two drawings to confirm that we're making an accurate diagnosis, just because it is a medication with significant risk, clots, increased cardiovascular adverse outcomes, growth of prostate. If you have an underlying prostate cancer that wasn't screened for, it can make that grow. Lots of things that we want to make sure we're using it, just properly. And also it makes you sterile while you're on it. So if somebody's trying for fertility and trying to have a baby and their wife is on all these hormonal treatments with their reproductive, this has actually happened to me. Wife is on all these therapies from her RE, her reproductive endocrinology, while the husband is getting testosterone from some random clinic that's not using evidence-based therapy, and the wife can't get pregnant because the guy has no sperm.
Wait, so you're saying that when the man gets testosterone treatment, he becomes sterile? That's counterintuitive, I think, to most of us.
Yeah. So testosterone, remember we talked about the adrenals, how when the body's getting cortisol from somewhere else, the brain says, hey, body, I don't need to make it anymore. Now, when you're getting testosterone from another source, the brain says, hey, body, we don't need to make it anymore. Our testes don't need to make it anymore. We're getting it from somewhere else. And so that makes men not infertile. When they stop the testosterone therapy, you can regain fertility after a few months. And then now we have something called Natesto, which is intranasal testosterone, that sperm counts have been shown to be preserved. So that might be an option for people with true hypogonadism who are trying to get pregnant. But yeah, it's really sad to see situations like that, because it's just, the patient, it's not the patient's fault. They just were counseled. They weren't counseled based on their goals and needs at that time.
So am I hearing you say that if somebody doesn't need testosterone and they take it, that will render them infertile? But if they do need testosterone and bring it up just to normal levels, they won't be infertile?
No, in both cases.
Oh, okay.
They would be infertile.
Okay. Yeah. Got it. Okay.
Wow, that's pretty. Speaking of testosterone, what about transgender patients that you might have who want to transition, are transitioning? How hard is it on the endocrine system infusing that level of hormones, for forever, or at least a very long time?
Yeah. So, honestly, their doses of testosterone aren't quite as high. So we would be basically doing a female to male transition. And I see patients like this fairly often. And they tolerate testosterone therapy really well. The only thing to remember in these patients, if you're, for example, their primary care physician, is they still, unless they have a surgery to remove them, they still have the female organs. So while they are a man, they still have ovaries, they still have a uterus, they still have those things. So we need to be doing the appropriate cancer screenings and screenings that we would do for a woman.
Okay, got it. Okay.
And they'll take the testosterone for the rest of their life, right?
So long as they, want to transition. Most of these patients don't want to come off testosterone because their body's not producing it on their own, and they're a man. And so, yeah. In order for those the effects of testosterone to stay, they'll have to be on it for the rest of their life.
I take hormone replacement therapy. I wanted to come see you, but I'm in California.
I know. Angie and Danielle have been trying to get me to get my California license for a while. And that's definitely the next state. If I get a next state, it's going to be California.
Yay. Tell me what you feel about HRT. And is it something that I've been on it for a long time? I'm 58. I've been on it since I was 46. And I know that we've had other doctors on who, think that's not a great thing. But I've also read about women going off HRT and being absolutely miserable. So give me the lowdown. Give it to me straight.
Yeah. So you mean estrogen?
Actually, I take estrogen, progesterone, and testosterone.
Okay. So with estrogen, there is some back and forth because there was some studies that showed increased risk of cardiovascular disease when you're on estrogen. Most people kind of think if you're on estrogen for 5 years postmenopause, you're probably in the clear. Longer than that, we might be dealing with some increased risk. Now, in the way menopause works, I'm assuming that you started it postmenopausally. Is that correct?
No, it was perimenopause.
Perimenopause.
Yeah.
Okay. So for menopausal symptoms, hot
Yeah.
flashes, something like that.
Mostly craziness and depression.
So basically what happens perimenopause, postmenopause is the ovaries aren't producing estrogen as much. They're kind of declining, but they still give off bursts. So when you get these bursts, people get drenching sweats and things like that. But over time, those symptoms start to decrease because you have more stability in the fact that your ovaries no longer produce estrogen. So that would be something that you might talk to your doctor about, because now you may not need it for the reasons that you may have needed it before. Progesterone is one that, it's not something that I prescribe it in my trans patients fairly often, and it does definitely, like, they all report mood stability with it. Now, I don't know how much, I'm not a GYN, and I don't deal with that as much. So I don't know how much evidence there is to support that, but from my trans clinical experience, people do experience that for sure in that population. So my suspicion is that it may be similar in women in general, but I don't know what the science says about that. In terms of testosterone, so there's one indication for testosterone in women, and it's hypoactive sexual desire disorder, HSDD, and that is decreased libido with significant impairment of quality of life. So if you're having decreased libido and it's affecting you emotionally, affecting your relationship, there may be a role for testosterone therapy for that. Now, in the US, we don't have like a dose that we know is accurate, or even a formulation that is routinely used. I think the guidelines on that even came out after I was in fellowship. So it's fairly new. We're still figuring out exactly how to treat that. What I will say is, other than that, there's no that isn't even based on the number, the testosterone number. It's just based on clinical, your clinical history. But there is no disorder of low testosterone in women. There's no evidence-based pathologic low testosterone number in women. And there are a lot of different formulations. The one formulation that is probably the most concerning is pellets. And that's because pellets can have variable bioavailability. And so if I give someone 30 milligrams, another person 30 milligrams, we don't know how that's going to be available in their tissues. It's just inconsistent. And so they're not FDA approved, and they're not indicated based on any sort of science, but they are kind of a cash procedure that is very, very commonly prescribed these days.
Those are pellets, by the way, everybody, that they kind of inject in you, and they, yeah. And my gynecologist has talked to me about them, and luckily my testosterone levels are good, so she didn't want me to take them, but she did mention them to me. So I'm really glad that you're telling me this. The estrogen, by the way, is mostly, I don't care about hot flashes, mostly for sexual, being able to have a vagina that is moist, and that's mostly why I take the estrogen and why I'm loath to lose it. So I'm worried.
Well, there are also some topical versions that don't have as much systemic absorption that can help with because that's a real thing, like vaginal dryness, vaginal atrophy that happens postmenopausally. And so, you can, it's a risk benefits conversation to have with your doctor, and you need to, and that's a very individualized thing. So I think that, some people, the risk outweighs the benefit, and some people the benefit outweighs the risk. And that's something that you kind of have to decide for yourself. And we as physicians are here to guide you and to say, okay, no, like, this is too risky, or, it does make sense, but you're really the patient is the driver of the ship.
Thank you. Thank you so much for that. I appreciate it. I hope it helped me a lot, and I hope our listeners too.
Of course.
You're just trying to give free advice. Come on our podcast and we'll tell you all of our problems.
I'd love to hear, just before we end, you yourself became plant-based quite recently, and your husband, and tell us about the positive changes that happened that inspired you to then recommend it to your patients.
Yeah. So in 2019, I was changing my job. I had a 6-month-old at home, as well as my daughter, who at that time was almost 3. And my husband's an ICU physician, and I was working full time at a very large endocrinology practice, seeing just tons and tons of patients a day, all week long. And our heads were spinning. Like, we were not in the best place. And I kind of had to extricate myself from that practice. But, I was 32 then, and I was feeling so fatigued. My joints were hurting. And I'm a pretty fit person. I never was obese or overweight. And so I just was kind of like, what is happening? I was getting really bad migraines. And our au pair, who was living with us at that time, was plant-based, and she was a nutritionist. And I got to the point where I was like, you know what, I need to do something. And so she really helped me learn about plant-based diet. And I switched in January of 2019 without any sort of plans to like go, feet first, like completely transform my lifestyle and my practice with it as a base. But then as soon as I switched, I started feeling so much better. And every time I would go back to eating how I had previously eaten, which I thought I was kind of healthy, but I don't think I was nearly as healthy, I would start feeling crummy again. And I was like, well, I don't have time for that. I'm a mom, I have 2 kids, I have this crazy job, I have this husband with this other crazy job. Like, I don't have time to be slow and to feel bad when I know there's a way that I can feel better. And so I decided to go plant-based. And when I was pregnant, my husband gained all the baby weight. And so he had gained like 30 or 40 pounds working. He was working full-time nights. And so he was like, well, if one person in the family is doing a diet, it doesn't make sense for us to do something different. And so, he went ahead and switched to plant-based diet and started intermittent fasting. And he was my patient 0. And he really, he lost all the weight and within few months. I don't know how men do that, but he did it. And he just felt so much healthier, more on point. His concentration was better. And he was like, I'm an ICU doctor. I need to be as on point as I can be. And so that was really the big switch. And then my mom kind of jumped on the bandwagon after watching us, and she has diabetes, but her A1C improved. She lost weight that she'd been trying to lose since as long as I can remember. And so those were my family were my experiments. But then I got really curious. I was like, okay, this worked on 3 people, and it didn't fail with any of them. Let me learn about the science. And that's when I really started getting more education on it, reading more about it, more studies. I got board certified in lifestyle medicine. And once I learned about it, I was like, oh, this is really important. And then I started this practice not knowing how it would go. And I luckily had a few patients who kind of took a leap with me, and they tried it. And the type 1 patient that I was talking about earlier was one of my first patients, and she did amazingly well. And then I just kept seeing patients do well, and more patients do well, and more evidence and more science coming out that supported it. And so, just have been running with it since.
That's an awesome story. The whole family involved in that story.
Yep.
So tell us how people can find you, because even if they don't live in Texas and right now aren't able to book an appointment with you, you do have information on your site and on your YouTube channel and on your Instagram, I guess, too.
Yeah. So I have, you can find me on Instagram. It's just Dr. Arti Thangudu. And then my website is www.sacomplete.com. And on that, there's a patient resources page that has a ton of resources, links to my YouTube channel and videos that I would be happy for y'all to take a look at if you need any more education on. We've got diabetes up, we've got thyroid up, testosterone up, and then there's more to come on adrenals, female hormones, all sorts of stuff coming up.
Don't take any bovine adrenals. It's snake oil, people.
Yeah, don't take any.
Your website, you said SA like San Antonio complete. Okay, we'll put it in the show notes, but want to make sure people have access. Okay, super.
Thank you so much, Dr. Thangudu.
Yeah,
you guys so much for having me.
So good. Hey, folks. Okay, back by very popular demand is our plant-powered plate fridge magnet, which you are going to receive for free if you leave us a rating and a review on whatever platform you're listening to this podcast on. So here are the details. Just write your quick review. Does not need to be long, does not need to be a whole story. Just be honest and speak from the heart. Then take a quick screenshot of the review you wrote and email it to us at podcast@switchforgood.org. That's podcast@switchforgood.org. And include your mailing address so we can send you a power plate. We are doing this because the more reviews we garner, the higher we go in search results, which means more folks will learn about our podcast. So the power is in your hands. Leave us a review and zoom, your power plate arrives at your doorstep.
So thank you so much for tuning in today. If we helped you in any way, then click the subscribe button and let's keep hanging out together. We have so much more to share with you.
And if you need more information on actually making the switch for good, please visit us at switchforgood.org for loads of info. And you can subscribe to our mailing list where you will receive all sorts of super cool gifts, discount codes to our very fave dairy-free products, and a lifetime of powerful health tips.
So join us on the journey to switch for good. This is the future.